Any advice given on Unity FM relating to health conditions must be verified by your doctor. General diet and physical and spiritual well-being is discussed on shows, but this is general only. If you have any medical condition or need medical advice, please consult a doctor.
Hello and assalamu alaikum, this is Ali. Got another interesting topic regarding ITU or intensive care unit. I have two lovely guests, Jane and Justine.
Yeah, my name's Jane Story. I'm a senior sister at Heartlands and Good Hope Hospital, and I work for the intensive care unit and the high dependency unit.
And I'm Justine Davey. I'm the head of fundraising for Good Hope Hospital, Heartlands Hospital, Solihull Hospital, and also Queen Elizabeth Hospital, Birmingham Charities.
Just a few then?
Just a couple, yeah. Keeps me busy.
Okay. So could you tell us a bit about ITU or HDU? Is that the same as?
Yeah, I can. There is differences between the intensive care unit, ITU, and the high dependency unit, HDU. The intensive care unit is where we have the sickest patients in the hospital, and we nurse them on a one-to-one basis. That's one nurse for one patient. And the HDU are patients that aren't quite ready for the ward, are still quite poorly, still need some extra support, and they're nursed with one nurse for two patients. And so that's the setup of the intensive care unit at high dependency. And obviously, because we get the sickest patients in the hospital, we have to be prepared for any eventuality. So there's a lot of equipment, a lot of resources there, a lot of staff to provide the best care for these patients within the hospital.
So ITU and ICU is more or less the same thing, just different words?
Yeah, it is. People can get confused with that. The intensive ITU, which is the intensive therapy unit, or ICU, intensive care unit, it's just a regional thing. People say one thing and another hospital say another thing. They mean exactly the same thing. It's the area, the intensive care unit, the intensive care unit. It means exactly the same thing.
So if you're visiting somebody, whichever one you're going to ask for, they're going to direct you to the same department.
They directly to the same department. The HDU is the high dependency unit, like I said, was a step down from ITU. And in some hospitals, like Good Hope, the high dependency unit is on the same. It's in the same place as the intensive care unit, and they flex the beds, whether it be high dependency or intensive care. But on a Heartland site, we've got one floor which is mainly intensive care, and the other floor which is mainly the high dependency unit. So they're two separate units.
Okay, so what are like the daily things that you would do in those units?
Yeah, as I said, we have to provide for any eventuality. So we've got equipment there for whatever the patient may come in with. We have patients that have chest complaints, heart attacks. They may have kidney problems. They may have had extensive surgery or complications, infectious diseases, all sorts of issues, sepsis, septicemia. So we have to have all the equipment and all the staff to give them the best care, whatever they come in with. So there's a lot going on. Some patients will need dialysis if they've got kidney failure. Some people may be on a breathing machine, what we call a ventilator, so to provide them with their breathing support. We use a lot of equipment for to monitor them. They have an awful lot of monitoring equipment, and I think this is quite daunting for relatives when they come to visit patients, because they just see their loved one in the middle of this array of machinery, and really it's an awful lot for them to take in. So we have to deal with all their drug therapy, making sure that all the drugs and everything they need is provided for, and all their treatment plans are initiated and given. So we deal with a huge amount of things that but rest assured the unit is there with the resources to provide these things, and if it can't, then in the very unusual circumstances, they're transferred to another hospital that can provide the resources. But majority of things we can provide for. Yeah,
because obviously a lot of the things that you would deal at Good Hope might not necessarily be dealt with Heartlands, and vice versa.
There's a small minority, and some will need specific, especially maybe neurosurgery, which is provided for at the Queen Elizabeth, which we don't do an awful lot of neurosurgery. So there are very few, but sometimes specific things where Artris can't provide for things, but majority of things, yes, we can. Yes, and we do. Yeah.
In there, always with an element of calm whenever you go into the ITU or to critical care, whatever you call it. It's professionalism to the last, and always very, very calm. And yeah, fantastic care.
I mean, I can imagine, because I have had the chance to kind of visit one of these ITUs. This was at Good Hope. I mean, you know how you say it can be quite scary at times. Even the bed is placed in the middle of the room, so everybody can move around. So
yes,
that is a reason. But yes, you can see so many equipments hanging down, wires and everything.
Yeah, but it's strange you say that, but everyone can see it, but usually the patient can't. Usually it's behind the patient, so they're not quite aware, and because they've been so poorly, of how much equipment is there to help support them. But the relatives certainly do, and they are quite shocked when they come in, and they need an awful lot of support by the staff while their loved ones are in the unit. Yeah.
I mean, some patients probably don't even remember half of this stuff that's going on to them.
Absolutely. Some people have absolutely no memory whatsoever, and not even the ITU or the HDU. Sometimes they can barely remember their stay on the ward. So when they get home, it's all a blur to them, and they really have lost that episode in their life. And there's a big gap that's missing. I'm sure we'll talk later on about how we can help provide some tools to get them to understand what happened to them. Yeah,
of course.
Yeah.
Right. So going back onto the same question, could you tell us a bit more about the team and what they do on a daily basis? Because obviously you've got so many members, and they're all qualified in different ways.
That's right. Yeah. Actually, on the intensive care unit and the high dependency unit, there's a huge team, and it's made up of a variety of people. I mean, obviously, the first people that most patients or relatives see is the staff, the nursing staff. And we've got over 140 staff, I think, well over that between the two sites of nurse at a nursing level.
This is Good Hope and Heartlands.
And Heartlands, yeah, on combined. And as I mentioned, the nurses are one-to-one, and the team there, the nurses are looking after the patient as a whole. They're there 24/7, looking at any consistent monitoring and seeing if there's any deterioration or improvement, and looking at the finite detail of how the patient responds to the treatment. But alongside them, you have got obviously your doctors, your consultants, and we have specialist consultants that deal with just intensive care patients, and they work alongside the patients of the consultants, say a kidney consultant or a chest consultant or anyone like that. So they work together as a team, the consultants, to give diagnosis and treatment plans for that patient so as they get the best care. But also you've got other doctors that work within the unit, specifically for the unit, and clinical nurse specialists that are also working alongside the unit. The patient also requires specialist advice for their nutrition. They have dietitians specifically that come up on a daily basis to the intensive care unit to make sure they're getting the right nutrition in the right way. It could be through tubes in their nose, through tubes in their arms. It could be a variety of ways they can get their nutrition. We have microbiologists that come on a daily basis to the unit, and they look at any infections they may have and the best antibiotics or the best ways to treat them. We have infection control staff that come up as well, and if there is certain infections, we need to quarantine the patients and isolate them. And so that's done. We have pharmacists that come up looking at their drug therapies, making sure we've got the right drugs. We have medical engineers that come up for all the equipment that we mentioned earlier, that they've got a variety of equipment, and that all has to be serviced, and if there's any faults or anything reported, and they come up and
because there's no room for error, really.
There's no room for error, and we need the equipment, so we can't take a load of equipment out for while they fiddle. They have to do it on request. And as you said, there's even the domestic staff. They're there and keep the place absolutely spotlessly clean. And there's we've got housekeepers that look after our stores and ordering to make sure we've got all the equipment we need for every eventuality, and that we never run out of everything. So it's a huge wheel, and we're all little cogs in this wheel to keep the intensive care unit going. So a lot of staff and a lot of teamwork, and communication is key between each area. So as everything's done and communicated directly at the patient's bed space, so as everyone knows what everyone's doing. And you'll probably notice if you ever go into an intensive care unit, and hopefully most of you won't, but you'll see nurses doing a lot of writing and doctors writing in notes, and that's making sure everything's communicated and everything's down on paper, what has been done and what needs to be done, so as everyone knows what's going on with that patient. So yeah, it's a big team, and a lot of communication needs to be disseminated between the teams.
And yet, when you do have to visit ITU, it seems really calm. And everything seems like there's nothing really going on here.
Yeah, I think it's a bit like the swan and then treading water underneath sort of thing, because it can be a noisy place with lots of alarms going off and things, and that can be quite daunting for a lot of people. Even within the medical profession, it can be that sort of noise, and every alarm, people think it's an emergency. It's not always. The alarms are just telling you, be careful, something might be happening here, or it may be sometimes they're that sensitive, some of the equipment, it's just giving you a warning. It doesn't mean that it's a terrible thing that's going to happen or anything like that. It's a warning. So yeah, it's a busy, noisy place, but I think the staff are quite calm. We're used to that environment. We're used to dealing with the sick patients, and so we have come across a lot of complications that do happen, and we know how to deal with these things. So yeah, I think the staff are very calm. And
I think it's really important for you to be that calm anyway, because when you're calm, you can actually collect your thought and decide what you're going to do with that particular patient and give them the right treatment.
That's right. You can organise your mind and decide what to do, and how you're going to do it within your work frame, because there's a lot to be done. People think, oh, what's one nurse going to do all day with one patient? And they'd be surprised how much work there is to be done. Although there's continuous monitoring, we have to document a lot of what's going on for that patient, and with giving their drugs, we're looking at their tissue, their skin, tissue viability, making sure all these areas that we've talked about, from the dietitians, the physios and everything, and all that is implemented in their care all the time, because these patients, as we mentioned, are unconscious. They're not able to do anything for themselves, so we have to make sure everything's covered, from pain control, diet, their skin health, their psychological health as well. Yes, even though they're unconscious, we do talk to them, explain what we're doing. I think people forget, when people are in a coma, or when you go to sleep, the last thing that goes is your hearing, and the first thing that wakes you up is your hearing. So we never know whether they may be able to hear, at what point that they're awake. I mean, most of the time they're unconscious and they won't have any memory, but sometimes they may be able to hear something. So we always encourage staff and relatives to talk to our patients and say what's going on and who they are and what they're going to do to the patient.
So if the person is in that state of coma, for example, would you know when they can or cannot hear?
No, because some of them, they can't respond to what you're saying, but it may give them comfort. In maybe subconsciously they may hear you. So we always talk to them. We always explain everything. Yeah.
That's good.
Okay.
So once you establish the person is stable, would you move them straight away onto a ward? What happens after they moved onto a ward?
Yeah, normally once someone doesn't want intensive care, then we move them onto a high dependency unit. Once they're off, say, the breathing machine or the dialysis machine or the large drugs that they're on, they've improved enough to go to the high dependency unit, but they're not quite ready for the ward really, so they just need some extra monitoring and supervision, just to make sure that things are continuing to improve and they progress. As I mentioned, our high dependency unit is one nurse for two patients, so they get that support, but it's a bit of a step down from the intensive care unit. They don't need as much support there. And some patients actually, or relatives as well, do feel fearful of just that move, let alone the move to the ward, only because they feel a little bit insecure and uncertain of being from one being the centre of attention, and then if they go to the ward, the step down's quite big. They may have a nurse that's looking after a bay and more patients, so the nurses aren't as visible as what we've been. We've been very visible. But in some ways that's a positive thing for the patients, because they're encouraged to do a bit more for themselves. In ITU and HTU, sometimes we do so much for them, and they need encouragement to do things for themselves, and going to the ward can be a positive step so as they can progress their rehabilitation.
But by no means that is when the person is completely healed. Obviously there's a lot more afterwards.
Yeah.
And they're not completely out of danger as you would think.
No. There can be setbacks, they do happen, but hopefully most people do continue to recover. But they have a lot of issues when they go to the ward, because they've been so ill, and they've had life-changing events that have happened on the intensive care or the high dependency unit, and when they go to the ward they still feel as though they have got a lack of appetite, for example. And some of that is when they're on ITU, they have a tube in their mouth that bypasses the taste buds and the nose, the sense of smell, and so these become a bit dormant, the taste buds and things.
Yes.
And so when they go to the ward they have no appetite, or things taste like cardboard or bitter or sweet. Depends which taste buds become more active than others, and so they find their taste change. Excuse me. So it takes a while for their appetite to get back. They have on the wards they lose a lot of muscle. When they're on ITU, they're not moving at all, and what little movement they do get when they start to progress to HTU is limited, because they still have lines and they're still quite sick. So when they get to the ward, they fatigue easily. They need a lot of physio support. They can lose up to, within the first week of ITU, up to lose over 25% of their muscle power. So that's a huge amount, it takes a long time to regain. And of course, that continues on while they're in the ward. They need a lot of physio support, and the fatigue, like as I say, it doesn't take much for them to be really tired. And the patients can get very frustrated with that, because they think because they're on the ward that they should be progressing, and they can see other people progressing quite well, and they're like, why aren't I progressing so well? But they haven't been in ITU, and the patients and relatives sometimes forget how ill they've been.
Of course, because a lot of times you would associate fatigue with, let's say, stroke patients or heart attacks, but if you're being bedbound more or less for 2-3 weeks, and then more if you're in a ward, that would affect anybody.
Yeah. I mean, for example, if you're at home with, say, the flu and you're in bed for a few days, you're really weak and fatigued afterwards, and you're moving around in the bed and doing little bits in the bed. But these patients are doing absolutely nothing. So they get extremely tired, and it takes a long time for them to gain that muscle. And I think some patients give themselves a bit of a hard time over it, and they shouldn't do. But they need a lot of support when they go to the ward. And they can also be quite low and quite fed up, because they're not progressing as they think they should. And this can impact them psychologically, and they feel as though they should be doing more. But it takes time. It takes a lot of time.
Which kind of moves on to the next question anyway. It's the road to recovery, dealing with, supporting with patients, or even their family members or friends.
Absolutely.
And how you just said it does take a lot of time.
It does. And when they get home, you've got to remember that when they're in hospital, they provided with meals, everything's cleaned for them, they don't have to do anything for themselves. Well, some people, when they're discharged home, haven't got a lot of family support, or they're on their own, or if they have got a lot of family support, that it's quite an awakening to see, gosh, I've got to do this for myself, I've got to think about things. You have your responsibilities for your home. You didn't have them in hospital if someone else is taking care of them, or they're being dealt with, so you've got a lot of issues to sort out yourself. And then as time goes by when they're at home, they're not progressing with their rehabilitation, their own getting up. They've got to do shopping, they've got to do tidying up the house and everything, and they're so fatigued and so weak, and they get annoyed with themselves that they're not doing as much as they should. But again, it can take months, up to over a year, to recover from a spell in intensive care unit. And I think people are a bit hard on themselves as why they're not progressing as well. And also psychologically, they can get quite depressed and quite low, or they can have mood swings. And some people have quite severe dreams or nightmares or hallucinations of the time that they were in ITU. And these can be quite disturbing because they're very vivid dreams, and they don't understand why they're not sleeping and whether it's all related to ITU, but a lot of the time it is. And usually within a few months this will pass, but sometimes if it doesn't, the occasional patient has led on to post-traumatic stress syndrome, which is quite serious really. So if any patients are still feeling depressed and low after a few months, and aren't getting themselves out and about and feeling as though they're staying at home because they feel safer at home. Yes. They get anxious about going out into crowds and with their own mobility. It's time to go to your GP and speak to them about it, because there is support out there, psychologist support for patients that don't feel as though they're coping mentally with being at home.
I mean, the one thing you just mentioned about hallucinations and everything, is that relating to when you mentioned earlier about when somebody's in a coma and they can listen to things, and are they like kind of like picturing things now, or? They
are. What happens is, do you remember we mentioned when they're in a coma, they can't make any memories. Their brain is switched off, basically. Yeah. So what the brain tries to do is make new memories, and it clutches at anything that it may hear. And we mentioned that they may be able to hear something or recognise something. And so there are quite some common themes with some of the dreams or hallucinations they have. And if we see patients like we do we have some coffee mornings, we can sometimes break down these dreams and say, well, that's because of A, B or C. A lot of patients dream about being in a boat, for example, but the bed undulates and it mimics like a boat effect. So it's a very common theme.
The airbeds, aren't they?
Airbeds, yeah. And so they move up and down continuously, so it gives them the feeling that they may be on a boat. So their body will make a memory of that. And also we have a lot of dreams about people that have been kidnapped by drug barons. Well, there's the use of the word drugs is bandied around quite a lot on the ITU, given their drugs and things like this. And the feeling of feeling trapped and kidnapped or things is a common theme, because they are tied down by all the equipment.
That makes sense.
And unconsciously they're aware of that. They can't move with tubes in their mouth and their neck and on their arms. And so there's common themes with some of the dreams and hallucinations they have. But obviously for the patient, these dreams are quite upsetting and quite vivid, and they really do feel that
more
these
like
things have happened. Yeah, they're really bad. And they don't leave them sometimes, and when they go home they're still having some flashbacks or bad dreams. Usually they will go after a few months, but again, if they're not, and they're not sleeping well, they're coming quite sleep deprived, and they're continuing with these dreams, it's time to go to the GP to seek advice, really, because sometimes they just need someone to go through them and talk to it about it.
Because I know if you're a stroke patient, they normally have like afterwards they have psychological support, which automatically, I think they give you a call or something.
Yeah.
And it's up to you if you want to take up on that or not. That's is right, confidential. Yeah. But then with ITU, it's in general. So remember that whoever's been in that situation and maybe in a coma or not, that's just besides any other issues that they might have.
Absolutely. And some hospitals do have a follow-up service. We've got something of a follow-up service where we do coffee mornings, where people are invited to come back and share their experience of what they've been through, and we're there, and sometimes a consultant's there as well to go through things that they're unsure about and what's going on, and we can explain them through. Because some patients do, when they get home, they find they get hair loss or brittle nails and things like that, and they're like, what's happening?
And it's not relating to their treatment.
And it's related to their stay in ITU. The body is very good at closing down and looking at the organs that are important, and the hair and the nails aren't important, so they get neglected, and as a consequence to that they can get hair loss and brittle bones or black nails, not brittle bones, brittle nails, and and that does resolve itself. 99% of cases will resolve themselves and it will come back to normal. But it's nice to know that could happen. So that's what we discuss.
Right, we're just going to take a short break now. We'll be back with you soon. Just remember, any topics that we discuss health related, do refer you to your doctor before taking our advice. Thank you. Hello, welcome back. Another interesting topic regarding ITU, or intensive care unit. I have two lovely guests, Jane and Justine.
Yeah, my name's Jane Story. I'm a senior sister at Heartlands and Good Hope Hospital, and I work for the intensive care unit and the high dependency unit.
And I'm Justine Davey. I'm the head of fundraising for Good Hope Hospital, Heartlands Hospital, Solihull Hospital, and also Queen Elizabeth Hospital, Birmingham Charities.
Just where we left off about Road to Recovery and how we deal with, I mean, this is really interesting what you just told us about how people have these hallucinations, and coming to these coffee morning kind of answers these questions. I mean, another way we just found out through this radio station, but can you carry on on that?
The coffee mornings are important. They're an area where we can give them advice on what's happened to them, and some of the patients want to go back to the unit to see where they were and what happened, because they've got huge gaps in what happened in the intensive care unit. As I mentioned earlier, some have got absolutely no memory at all. Some have bits of memory, and when they go to where they were, they can sometimes say, oh, I remembered why I was dreaming of that because of that picture on the wall. I thought it was so-and-so.
Yeah, or we could be talking about something, maybe football or cricket, and they might be thinking themselves playing the game.
That game, yeah. And also we encourage the relatives to write a diary of, a day-to-day diary of what's happened to their loved ones. And it can be anything about their progress in ITU, but also things like if it was their anniversary or their football team, whether they played that day, just to put some perspective into what they're writing. And then afterwards, when they go home, they can go through this diary and fill in some of the gaps. Now, some patients, fair enough, don't want to do that. They're a bit scared and they don't want to know what's happened, and that's fine. That's absolutely fine. But we also find that the diaries help the relatives. It helps them. It's a bit cathartic for them to write down what's happened to their patient, so as they know, and it's all down, because it's amazing how quickly you forget what's happened, because it all blurs into one, because it's such a stressful time for everybody. So it's a good tool for them to have. And a lot of the patients, when they go home, they do suffer from short-term memory loss, and which can be frustrating for them. And they also have problems with their concentration or their attention span, and they're thinking, oh, I used to read loads of books. I've had some patients that have come back and says, I used to read 3 or 4 books a week, and now I can't get through one book. I haven't got the concentration, or they could follow a soap and they can't now. And again, it's because of the impact it's had on their body, their attention span is affected, and their short-term memory. But that will improve.
Yeah, I mean, I've met people who've been in intensive care for one reason or another, and one of the other things they mentioned was they used to watch a lot of sitcoms.
Yes.
And afterwards, they didn't find them funny at all. I mean, they could watch it. This is something that they've been watching religiously every week, and they could sit there, watch the catch up is all, and they find it funny every single time. But then afterwards, maybe because what you just said, the attention span isn't there.
It isn't there.
They don't find it funny anymore.
No.
And it's like, okay,
Yeah.
it's funny, but nothing to go crazy over.
Absolutely. And you'll find that some patients, like I said, they'd watch their favourite soap every week, and then they'll find they watch the first 5 minutes and their mind's somewhere else. They just cannot concentrate.
As before,
for a long
they
period.
just didn't even like if somebody spoke in between.
Yeah.
And now they're kind of like in another world sort of thing.
Yeah. So coming together, doing coffee mornings, I feel is beneficial for the patients, and the feedback that we have had has been positive, and so we will continue to do these, and hopefully reach out and see if there's anything else that we learn from it as well, because from their feedback we can change our practice in some areas, and there may be something that they notice that we've never thought of changing, so it benefits both.
Yes, of course, and it benefits the person who lives with them, so it could be the spouse or could be mom, dad, anybody. And it answers the questions for them as well, why their son or daughter has been acting the way they have.
Absolutely.
Or the other option is just ask.
That's it. And sometimes we have physios that come to the coffee mornings, and they can give them advice on physio and whether they need extra physio still. So it's all good.
So besides that, is there any other way our listeners can help or support in any way?
Well, currently what we're doing at the moment is there's 38 staff on the ITU and the outreach service that we do. And by outreach, I mean staff that go to the wards and follow up the patients after they've been in ITU and H2 to make sure things are going well. And we're all doing a wolf run, and which is an obstacle course, and running in an obstacle, a bit like an army obstacle course, but not quite as bad as that, I don't think. Very muddy, I hear, and we're all doing that to try and raise money for the intensive care unit.
Okay.
When
is this?
This is the 7th of April, which is a week on Saturday. So yes.
And can they still join?
I'm not sure on it's. I think they've actually closed registration for it, to be honest with you, but actually it's one of the it is the largest team of nurses, doctors, outreach staff who've ever taken part. I have to say, Jane has forgotten to mention that actually it's a 10k run. It's not just a small walk in the park.
No, it is.
And I think it's something like, I'm not scaring you in any way, Jane, I do apologise.
I'm trying to, I'm in denial.
It's probably about 20 or 30 different obstacles, and they are kind of army related, to be fair. But it's fantastic from a charity's point of view that we've got so many staff who clearly believe in what they do, and you can hear from Jane how passionate she is about what she does, and absolutely the money that they raise, and people who've either been affected and have been into intensive care unit or been to any of the hospitals, they can make a difference. And as a charity, we host a whole load of events ourselves. We encourage people to take part in Clearly Getting Very Muddy, and all of the funds come into the hospitals and into the funds that they want it to go to. That's very important. The money that the staff are raising will actually go to ITU. It won't go anywhere else. That's the whole point of it. And yes, anybody who wants to take part in any event, really, to be honest with you, be it a skydive or be it a community team that just want to do a lovely cake sale or have a family day, because it's not just about, one of the things Jane's mentioned is it's not just about the patient, it's also about the family. So as a charity as well, and the hospital charity, we support the patients and the families. So if people want to get involved and raise money, they can go to our website, which is heft.org.uk, or just Google us. Google knows everything.
Of course. Right, so thank you both for coming in. It was really interesting. Jane, Justine, both of you.
Thank you for having us.
Oh, that's fine. You're welcome.
It was good. Thank you.
Thank you. Bye. And again, just to remind you, if there's anything that you were unsure about, speak to your GP or your consultant.
Any advice given on Unity FM relating to health conditions must be verified by your doctor. General diet and physical and spiritual well-being is discussed on shows, but this is general only. If you have any medical condition or need medical advice, please consult a doctor.